All right. Good evening, everyone, and thank you very much for joining us for another, or rather, our final Aorta Chat interview of the month. My name is Adam Ahmed. I'm a medical student from CUNY, and we're very lucky this evening to host Dr. Eric Roselli.
Hi,
Dr.
Adam.
How you doing? Dr. Roselli is the chief of the adult cardiac surgery department in the Cleveland Clinic. Where he also serves as the director of the Aorta Center. As a staff surgeon, Dr. Roselli regularly performs over 300 operations annually. He's internationally recognized for his work in cardiac and aortic surgery, as well as for his expertise in cardio-aortic interventions, including but not limited to aortic valve repair, endovascular and hybrid repair of aneurysms and dissections. Dr. Roselli, thank you very much for joining us. How are you today?
Great, Adam. We had a nice day in the OR today, huh?
Always.
Yeah, and always happy to talk about cardiac surgery. It's awesome what we do, and excited to talk to people that are interested in it.
All right, great. So for our students listening in and uh, patient members as well, maybe we could start by hearing a little bit about your inspirations for becoming a cardiac surgeon, and then what led you to subspecialize within aortic surgery.
Um, yeah, I mean, I think we talked about it in the operating room the other day. I kind of always knew I wanted to be a physician. It was something that um, my grandmother sort of instilled in me, this idea that the altruistic nature of this work is the most noble profession. Um, um, I'm first generation American, and my older brother was a first college student in our family, and so education was something that was stressed. My grandmother wanted to be a physician, but never had any opportunities, and I was really close with her, and I think that's probably where I got my first inspiration to go into medicine. But cardiac surgery was not anything I thought about when I was young. I just I wanted to be a doctor. And then in med school, I think, you figure it out. Certainly the med students on this call will appreciate this. Kind of one of the first decisions I think you have to make is, um, am I going to go kind of a medicine route or a surgery route, right? And even though, the kind of more modern hospital organization, certainly at the Cleveland Clinic, is more around disease specific institutes and whatnot. When it comes to your own personal decision, and you have to think about how your personality sort of fits different um, strategies of delivering healthcare. Are you kind of a surgeon personality or a medicine personality? I think, and certainly there's some specialties that cross those things, and and as surgeons, we have to kind of own the diseases that we treat. But I knew earlier that I wanted to be a surgeon, and then I always sort of in my life have stepped back and thought about important principles uh, before I make decisions. And one of the things that I recognized was important to me was take care of patients who were really sick. I like that. Maybe I need that to motivate me. I mean, I thought plastic surgery was cool. Wasn't sure I'd get motivated by the cosmetic part of the operations, although there's certainly, great value provided in some of those facial reconstructions and things like that. And thought I'd maybe be an ENT cancer surgeon. And then I kept finding myself kind of coming back to the heart. I did the best in all the kind of heart blocks in the early parts of med school. Um, I stumbled upon some research when I was a med student with cardiac surgeon and a hemostasis expert. We studied aprotein. Um, I really just started out thinking maybe I wanted to make a few extra bucks because you don't ever have any free money, and then realized that the research was really cool. So a lot of sort of serendipitous things and opportunities that came up that kind of kept pointing me in that direction. Did a rotation for a couple of weeks in elective that was a cardiac surgery elective. And when I showed up as a third year rotating on cardiac, they were like, "What are you doing here? We don't get any students going through cardiac ever." And I said, "Well, I want to see what you guys do." And I loved it. It was really cool. And they were very welcoming, and I enjoyed that. And so a lot of things kept bringing me back to that. And then there wasn't an integrated residency program for me back when I was training. It was two residencies. First, you do general surgery, and then you apply again to do a cardiothoracic surgery residency. And about halfway through my general surgery residency, I was trying to figure out what I was going to do, and I was thinking maybe hepatobiliary, maybe kind of some of the really advanced laparoscopic stuff was starting to happen. Like the first Whipple was done here when I was a general surgery resident here. Laparoscopic Whipple, I mean. And um, but I really liked the cardiac stuff. So when I rotated through what was already a dedicated thoracic rotation, I asked if I could get an extra month in there and spend a couple months in cardiac, a couple months in thoracic. And once I kind of hung out with the team and was in that space, working with people, taking care of those problems, that really kind of excited me. I just knew, and it's hard because now you gotta make a decision right off the bat when you're graduating whether you're going to do this. It's nice. The integrated residency programs are great. I didn't have to make that decision because I couldn't, but I don't think there were we were set up like that. Like I said, I showed up on a cardiac surgery rotation, a med student. They were like, "What are you doing here?" They were used to not meeting anybody until they were sort of several years through training. Now the integrated residency programs, we're warm and welcoming to people who want to, do what we do or are interested in doing what we do. And I think you've got to spend some time in certainly in a cardiothoracic surgery operating room to get a sense if that's a place that feels right to you. You can make lists, pros and cons, and do all these things. But your, you know, the posterior part of your cerebrum is going to help you process a whole lot of other things. And you're going to just kind of have a sense of whether this is the thing that you want to do or not.
It's wonderful.
Long answer, but
No.
it didn't just, it wasn't just like I said, I'm going to be a cardiac surgeon when I was a high school kid. I had no idea,
And it was nurtured over time, I'm sure.
nurtured over time. And then you asked me about how I became an aorta specialist. Well, I loved every part of cardiothoracic surgery when I was doing my residency, and I was getting to the point in my senior, my final year, where I had to start looking for a job. And Bruce Lytle, who was the chairman here, called me to his office one night or one morning, kind of after a long night. I was on call the night before, and we didn't go home post call. There was no work hours at the time. No, so he called me to his office, and he never called me into his office, for stuff in the morning. I thought, shit, maybe I killed somebody or something last night or screwed something up. I was going to get an earful.
Yeah.
Oh, typically that stuff wouldn't have been a surprise to me, but I didn't know why he was calling me in his office. And he sat me down and he said, "Hey, Eric," he says, "I know you were thinking about doing heart failure and transplant," because I had just sort of finished a 3-month rotation working really closely with Nick Smadera, who's, one of my partners here, but has always kind of been one of my important mentors. And we had a great time. We did all these, we did a couple total hearts, total artificial hearts, and a bunch of ECMO cases and a bunch of VADs and a bunch of transplants. And at the time, the fellow that we had that was like kind of my co-fellow was someone I don't think they really even wanted to be here. So I just worked my butt off along with Smadir. We had a great time. He was talking to me about how, they've been sort of talking about maybe trying to get me to stay and work with him. And at least that was what he had been thinking. Anyway, so I thought that's what I was going to do. And when Lytle said, "Hey, I know you've been talking about transplant, but I need an aortic surgeon."
Mm.
And he says, "I don't want you to say anything. I want you to just think about it." I was like, wait a minute. After going in there thinking like he's going to rip me one for screwing something up the night before, he's offering me a job. Are you offering me a job? And he said, "Yeah, but I want you to sort of think it over." I go, "There's nothing to think about. Like working here at the Cleveland Clinic would be the greatest. I love it here." But I told him, I said, "But if I'm going to be and aorta's super cool too. Like I did my general surgery training here and worked with all the vascular guys. Roy Greenberg is here, who's really the the grandfather of all this kind of branched end grafting and stuff like that.
Mhm.
Roy invented a whole bunch of that stuff, and he was a friend of mine. I said, but if I'm going to do thoracic aortic surgery as a sort of subspecialty, I think we need to find a way for me to get a little more endovascular training.
Mhm.
This was 2004, right before TAVR trials first started, and we were one of the first centers and partner. So like there was this sort of just whole sort of momentum sort of building towards cardiac surgeons and catheter wire skills. And Lionel said, well, that's exactly what I had in mind.
Mhm.
Um, and then that first year, my charge was to learn how to be a hybrid aortic trained cardiothoracic surgeon because there weren't any at the time. So it was like it was me, a guy named um, 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 gosh, I'm blanking on his name right now. Um, Michael Davidson. So sorry, I can't believe I forgot Mike's name. It's a tragic story. Side note, he was like murdered by a patient's disgruntled son. Crazy story. Um, uh, and 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 uh, and then another guy. Anyway, so we were learning how to get this hybrid training, and I spent a bunch of time with Roy in vascular surgery. I went and spent a couple months in a cath lab
Mhm.
learning how to do cardiac caths. And then when we were starting all the TAVR trials, I was involved in all those early cases, and so my practice sort of evolved as this skill set sort of grew. And then along the way, been sort of trying to figure out how we can sort of um, you know embrace all of these new technologies and redefine the way we treat aortic disease
Right.
because there's a lot of bad problems that we would see that really needed some new solutions. And I think, like, what the case we just did is a perfect example of us using a bunch of endovascular technology in combination with open surgery to take care of something that's uh, clearly a complex problem. Just juxtapose what we did in that hybrid room this afternoon to that open thoracoabdominal we did down the hall this morning.
Right.
Two very different approaches for the same kind of problem.
And how would you advise people to embrace and master these new technologies while also maintaining maybe more time-tested principles of aortic surgery? How do you strike that balance? Best practice.
Well, one of the things I always tell all the trainees, residents, fellows, students is catheters and wires are just instruments, right? And so, again, sort of getting back to in everything that you do, you should think about sort of first principles, like when you're handling an instrument, um, as you want to kind of master it, understand what it really is, right? It's there's all these names of these instruments, this whole vocabulary that you have to learn, and it's overwhelming. But when it breaks down, it's just a way for you to sort of get your hand closer to the patient, to the area of interest, to the disease segment you want to fix, to deliver some therapy. And so, when I'm holding a needle driver and I'm sewing a coronary artery with a 7-0 or an 8-0 needle, I'm transferring this kind of vision in my brain to the tips of my fingers through that, 12 centimeter instrument to a small needle at the end of it to deliver that suture. And so, I always talk about like be the needle. In your mind, you gotta get like this vision of what you want to do down into that small space. But when you do catheter and endovascular sort of procedures, it's no different than that, except the instrument is 100 centimeters long. And so the movements from your fingers and the idea in your mind where you want the end of that instrument to go is transferred to the end of that very long instrument. And instead of you looking down towards your hands, you're looking up at a screen. And that's a little awkward because it's natural to look down towards your hands. But if you think about it, when you're using a conventional surgical instrument, even though you're looking towards your hands, you're not looking at your hands. Your hands are still attached to your wrists. They always will be. You're looking at the end of the instrument. And so you have to sort of learn to use those other tools when you're doing endovascular stuff where you're looking at the end of the instrument. You just have to remind yourself to kind of pick up your head and look at the screen and understand that when you're transferring a movement down a 100 centimeter length instrument, there's a couple of nanoseconds of time for your forces to be delivered to the end of that long device. So, you move here, you got to give it time to see that little lag in time where the movement is transferred to what's happening in the instrument on the screen. And you can train your brain to kind of handle those instruments in a way where they become second nature, just like the way handling a forceps and a needle driver becomes second nature when you practice enough. And when you're a med student, like you should have a needle driver in your pocket and a forceps or some clicking instrument in your pocket. So you're like opening and closing and spinning that thing around like all day long. And you should have a packet of ties in your pocket. So you're like tying knots on everything, on the loops of your scrub pants or wherever you practice tying knots, and you get your fingers moving so that all those kind of raw skills, those fundamental skills, just become second nature. Just like you would if you were an athlete. When you're becoming a professional, like they don't need to teach the pro basketball player how to square up and shoot. They need to teach them schemes, right? So, as you kind of move along from being a student that's interested in surgery to becoming a resident, try and get some of those basic skills down so that when you're in an operating room as a resident, you can start thinking like the way a surgeon thinks, like think through the problems, think through how to manage the disease, not focus on handling a needle. And those are really important things. Those are simple things that you can practice all the time at home.
Right. My family will have you to thank when they hear clicking noises.
Yes.
Every day.
Yes. The nurses will get you an instrument to handle and use.
Absolutely. We do have some patient listeners as well that have been tuning into this series. So if we could shift gears a little bit towards them.
Sure.
What are some common concerns patients bring to you when you tell them they need aortic surgery, and how do you help guide them?
Yeah. I think in any kind of surgery, like a lot of the diagnoses we're taking care of, people know they're life-threatening problems. And so they're scared. And so they're scared, though, not of the things you'd think to be scared of. Yeah, they'll tell you, yeah, you're going to crack my chest open, and all these things that they hear. What they're really scared of is the unknown. They're scared of the unknown. And so our job is to teach them about what they're gonna expect. And I think, you need to tell your patients that you're gonna take care of them. You need to just tell them they want you to look them in the eyes and hear from you that you're gonna help them with this scary unknown thing that they're about to go through, that you're confident and comfortable taking care of because it's what you do every day. That's the messages you need to leave. So yeah, they're gonna ask you all kinds of questions like, is it gonna hurt? And how long am I gonna be in the hospital? And how long is it gonna take me to recover? Am I gonna get back to doing the things I want to do? Am I gonna live a normal life? People want to live, and they understand that the problem that they have when they come to see you is something really serious. And I find that if you educate people about what they're about to go through and they have the sense that you're being honest and genuine with them, you can tell them like, they want to hear it straight up from you. They don't want to hear a bunch of baloney. They don't want to hear you talking around in circles. Say it like, don't be crude or rude or, you got to be compassionate, but you can be honest and, and very straightforward about things and still be compassionate in your delivery of that sort of teaching about the experience. And patients appreciate it. And you see they calm down. I see the wrinkles in their face sort of fade away as they kind of like, okay, this guy's got me. This team is going to take care of me. They've answered my questions the best they can. And then you see when patients are in that sort of state where they feel comfortable and they trust you, they do better too, because they're ready. They get their game face on and they go.
And I wanted to ask a little bit about your practice here at Cleveland. I know obviously you spent a lot of time here, first as a trainee and now as a staff surgeon in one of the busiest centers in the world. What does it mean to you to be able to help serve this community that you trained with and you did? Well, how does it inspire your practice?
Being in Cleveland, the Cleveland Clinic, it's really awesome. Again, I matched here as a resident and honestly was not as prepared as you and the way you guys are today, like really knowledgeable about like what you're getting into. For us, it was just a lot of talk amongst people. We had electronic sources, but we didn't have like all the information and all the different sort of sharing of experiences. What I'm saying was I didn't expect to come to Cleveland. It wasn't number one on my list of the match. I just ended up here. I thought I was going to be in a bigger city. I was a young guy. I was like, Cleveland was not that attractive after coming out of Chicago, right? And then I realized I'm in this place that's this international beacon of people who come from all over the world for care and to train. And I was amazed at the experience here. And I've been here for 27 years, and I think I've seen probably 25 new buildings go up. And I've got friends that I've had here the whole time I've been here, who are now in many other have come and gone to many other parts of the world. And there is a sense of family of being here at the Cleveland Clinic, which is really awesome. And not just with the physicians and people I've trained with all the other people I work with. I think what makes this place special is there's this culture of knowing that you're part of something bigger than you. The people certainly certainly in our department of cardiothoracic surgery, everybody that works here wants to be the best in the world. And that's a real privilege that I always appreciate, never take for granted. The local community here in Cleveland makes up a lot of the workforce here. I know people in every part of this building that I've known for years who support the mission of taking care of people. So I know the people that are the unit secretaries and people that are on the um, environmental services team that clean our operating rooms that have worked here for decades, and on the police force, and every other part of this sort of community. And everybody I think gets that culture, that idea that we're part of a special place. And so that means a lot, right? I mean, I feel like I'm a part of this place. But it's this giant hospital system, and one day I'll retire and I'll move on, and it'll still be here. But that's also kind of comforting too, to know that as long as we got a whole bunch of people that sort of subscribe to this mission, that we'll be able to kind of continue to deliver care. I just want to do what I can to advance that along the way. and I have the beauty of taking care of patients one at a time and as part of that process and training people like yourself and all the other residents and fellows. And I hope that they bring some of that sort of spirit with them to the places where they work too, because um, you have a better experience when you work with people that care about each other and kind of understand that higher calling of what we do.
Absolutely. And I think that culture is really propagated throughout, all your trainees and all the people that you've helped train in this field. So
It's a good group, isn't it? Yeah, you got to know some of the residents here. Yeah, it's great.
I know you had a long day operating and you have an even longer one tomorrow, so I don't want to take up too much of your time, but I was wondering if you could give any closing words for our student audience members as they continue on their journey.
Yeah, so a lot of the students are sort of in different phases here, right? We got some who are interested in surgery, not sure what they want to do yet. Some are sure they want to do cardiothoracic surgery.
We got high school students and people who just applied last week.
Every level.
We got every
level. Yeah. Well, listen, don't worry about making too strict of plans for yourself. Like, remember what's important about sort of, what you want to do. And when you're making plans for like what your next phase of your career and your education is going to look like, focus on what the next couple of years are going to look like. 2 or 3 year plans are good plans because it takes a couple of years sometimes to accomplish something really serious. And you can do that and you can reflect upon it and you can move through that. It drives me nuts when people say, where do you see yourself in 10 years? Oh no, like every 3 years, if I look back, I'm a completely different person than I was 3 years ago. My desires change, my outlook on things change, my perspectives change. I mean, if you're continuously reflective about kind of where you want to go, where you are, where you've been, you will be changing along the way. And so I'm not saying, be flighty and fly all over the place. You can't do medicine if you're not making plans. But think about sort of 2 and 3 year plans, not 10 and 20-year plans. You might have some of those ideas in your head, but don't get too married to any of those. You might miss the opportunities along the way if you do. So opportunities have come up to me, in so many ways throughout my life. And I've been fortunate to sort of recognize them when they come along and have people around me to sort of help me, like, create visions for each of those sort of plans that I've created. And then, my wife taught me when we started dating, we were just getting serious, and she said she wanted us to sit down every 6 weeks and discuss, where we are in the relationship. And I was like, that totally freaked me out when I was like a 27-year-old guy. But it's really a wise piece of advice. And I've tried to sort of make sure that I do that in my own life, because it's a really crazy world that we live in as a cardiothoracic surgeon, right? To do this job, you've got to be a person that lives in a moment, right? You live in a moment like right now when there is a vessel that's loose and there's blood squirting over your shoulder. Like, you got to put your finger on it and fix it now, and you can't be distracted by anything else, right? So you're going to do this job really well. You have to live in the moment. And yet you don't get to do that job unless you're a person that's reflective about making long-term plans and looking down the road. So how do you be good at both? And I think the answer is you make sure you take care of yourself. And you do get up, and you get up and you show up every day. But every once in a while, I don't know, take time on the weekend or every couple of weeks to like sit down with some quiet time by yourself, take a deep breath, and reflect on what the heck you did the last few weeks or the last months or so, because you're going to be running, especially when you're doing your surgery residency, you're going to be running through things one after another, chasing down one sick patient after another, doing all the stuff that you need to do. You need to step back and say, all right, am I happy? Am I having fun doing this? Is this cool? Are the people I'm working with great? Is this really what I want to do? Do that every once in a while. And that sort of helps, I think, to give you the kind of perspective and that sort of appreciation for how time moves fast and slow. So again, my advice to the students is make sure you're always having fun with it, you know, enjoy the ride, enjoy the moments. Like some of my favorite times when I was a surgery resident or even a surgery student on a rotation was being on call because you're like in charge, man. You're like it's scary as hell, but you're also in charge. You learn so much. You could be all cranky and like be pissed off that you got to spend the night in on call and it's like, Lions are playing on Monday Night Football tonight. Or or you can just say, hey, here I am. I'm gonna embrace this. I'm gonna have fun with it. I'm in it. I'm gonna live in the moment. I'm gonna make the best of it. And that's how you have to kind of choose to live this. And if you do that and you reflect and you say, you know what, I'm actually having fun with this. I'm getting pleasure from the kind of the ups. I'm learning how to forgive myself from the downs. You take ownership of things, and there will be bad things, and you have to kind of own those things. You'll continue to grow. And for me, this has been one of the most rewarding things in my life has been able to be a cardiothoracic surgeon. I found what I'm supposed to do.
Amazing. I think all of our audience members are trying to do the same. So
Yeah.
thank you so much.
Yeah. Don't overthink it. Have fun.
That's it.
And
You're
our
ready to
patient just left the OR, so we're good.
Wonderful.
Yeah.
Perfect way to end the interview.
That's right.
All right. Well, thank you so much again for taking this time. All the students appreciate it. The TSMA appreciates it.
Of course.
Thank you to everyone who's been tuning into this series for Aortic Disease Awareness Month. Best of luck and good luck with your training.
Great job, Adam.
Take care.